Our commissioners, please have a seat at the table. And then our honored work group members and guests and others who are joining us here today, please grab a seat around the perimeter of the room. We'd appreciate that. Thank you. If you haven't had a chance to sign in, please do so at the front. And there's a few extra meeting materials there, as well as some materials from the last meeting for those of you who didn't get here then. I'm Nina Brewster. I'm one of the co-chairs, and I'm here with Boris Lushniak, an additional co-chair. Tosin Olateju, who's also an additional co-chair of the Commission on Public Health. And meeting today is being supported by our support staff, Sarah Koch, who's here as well, and will be monitoring the chat box for us. So thank you, Chair. I do want to say thank you, a big thank you to Dr. Branch and Kathy Wynn and his whole team from the Baltimore Department of Health for hosting the meetings for the Commission on Public Health. We're just very, very grateful to them for their time and for all the wonderful refreshments that they're providing, and certainly just incredible graciousness as host of this meeting. Thank you, Dr. Branch. This meeting is video recorded, and the video recorded has started. So participation, ongoing participation in the meeting is your consent to be video recorded. Our meeting roll call and discussion items, by virtue of time and by virtue of needing to offer the opportunity to the appointed commission members, will be primarily focused on the commission members. So those commissioners who are sitting around the table, we'll do a roll call for you, and we invite your questions, comments, discussion throughout the meeting. For those of you joining who are work group members, I'm sorry, we're not going to do a formal roll call for work group members. There is an opportunity to sign in for those of you who are here in person up at the front. If you're online, please consider as a work group member putting your name and work group affiliation in the chat box so we can keep a record of that as well. If we have time with the presentations, we will try to get to the questions and comments from our non-commissioner work group members. If we do not get to your question or comment, I apologize in advance. Please consider sending your question or comment to the Maryland Commission on Public Health email address, which is md.coph@maryland.gov. Thank you. Sarah Koch will begin the roll call for today's meeting. Thank you, Sarah.
Thanks, Dr. Brewster. So commissioners, please say here or present when I call your name, and just correct me if I mispronounce it. Delegate Heather Bagnall. Ms. Neil Blakefall.
Here.
Present. Dr. Gregory Branch.
Present.
Dr. Mina Brewster. Dr. Christopher Brandt. Ms. Jean Drummond. Dr. Nilesh Kaliraman.
Here.
Senator Ariana Kelly. Ms. Alyssa Lord. Dr. Boris Lushniak.
Here.
Dr. Tosin Olateju.
Here.
Ms. Fran Phillips.
Here.
Dr. Nicole Rochester.
Here.
Dr. Maura Rossman. Ms. Michelle Spencer.
Present.
Mr. Alan Twig.
Here.
Thanks.
Sarah, do we have at least 50% of our commissioners present?
Yes.
Wonderful. So we have quorum. Thank you so much, Sarah. We'll start with the first item, which is an adoption of the agenda. I direct your attention to the meeting materials. The commissioners who are online or in person, you can see a copy of the agenda in your folders, and would take a motion to approve. Any discussion, changes to the agenda? All in favor?
Aye.
Okay. Any nays? Abstentions? Thank you. Sarah, those online, if you could indicate your agreement or dissent somehow, that'd be great. Chat box, perhaps. Thank you. All right, thank you. All right, the motion is approved for the adoption of the agenda. Next motion is for the January minutes review. And your meeting materials, you see a copy of the January minutes. We'll entertain a motion and move into discussion. Would anybody like to make the motion? I'll make the motion. Thank you. And second, thank you. Any discussion on the minutes corrections?
Gregory W.
Got it. Thank you. Any other edits to the minutes? For record? Ms. Camille, I think you mentioned your name.
That's my number. Yep.
Great, thank you. So we'll remove the hyphen between Blake and Fall. Any other edits to the minutes? Okay. Great, thank you for the discussion. We'll, with the amendments that we've discussed, all those in favor? Aye. Great. Any nays? Any abstentions? Great. How about online? All right. Great. Thank you, Alan. All right. Great. Thank you. So the minutes have been approved as amended. All right. We'll move into, we just wanted to acknowledge that we've got some really special guests in the room. You'll hear about the presenters in a moment. But I did want to acknowledge Dr. Judy Monroe and Megan Roney from her team at the CDC Foundation. You heard from Dr. Monroe virtually last time at our January Commission on Public Health meeting. She is the president and CEO of the CDC Foundation with a long history in public health, both at state and national levels. And we're excited that both of them have joined us from outside of Maryland to be at today's meeting. Thank you very much for being here today. All right, and also our presenters are here from the Public Health Accreditation Board, and you'll hear about both Rena and Jessica in a moment. Thank you for being here. For new business, we'll go into the first item, which is the revised timeline for the Commission on Public Health, and I'll pass it over to Dr. Lucian.
Great. Let me present to you, members of the Commission, sort of activities that have been going on regarding timeline. First and foremost, just to report back to Commission members, the meeting that took place in Annapolis this past Friday. It was strange to have, obviously, the scenario of the week before we had snow, and that day it was like 80 degrees. So you know how weird it was that we were actually very warm in a meeting room at the Capitol. That being said, we also were informed the night before that the Senate had gone pro forma for the next day, so we realized we had to make an audible switch to making the meeting not only available in person, which is our desire, but it went hybrid rather quickly. So we thank our staff and the staff support at the Capitol for us to be able to switch rather quickly. Attendance at that meeting included Delegate Mark Chang, who's on the Appropriations Committee, a representative from Senator Kelly's office, and then representatives from the Maryland Community Health Resources Commission, the Maryland Healthcare Commission, other support staff for our commission, and 5 commissioners were also present at that meeting. What we tried to sort of share with this group of individuals were some of the concerns that we've had already expressed in the first few months of our activity, and I will lump them together. And I won't do it in the form of complaining. I will, however, do it in the form of the big headline. 1 is timeline, 2 is funding, and 3 is staffing. And so we had a very robust discussion over the course of 2 hours, which was partly us describing, here's what it's about. Some individuals needed to get the Commission 101 lecture, and others who knew about the Commission already had to hear that again, obviously the commissioners, but I think we did a good job in terms of explaining both where we are in terms of aspirations, i.e. we all know why we're here as volunteers, commissioners, and we're group members and friends. We're here so that we can change the world of public health in the state of Maryland. That's the reality. And if we don't believe we can do that, then we have an issue, right? We can complain all we want about some of these things that are potential challenges, but we need to have that belief structure, and we share that with the individuals in the room. That being said, ultimately the conversation went to this idea of what is the right timeline for this. We know what timeline exists within legislation. We know we've heard from commissioners in our past meetings and from the co-chairs themselves that we are not necessarily comfortable with this. And what we're trying to sort of go through is the idea of what are the alternatives. And our goal today is really for the commission to come up with what is their recommended timeline. Now, the pathway of how do we get to that still needs to unfold. We spoke with some of the the political supporters or the legislative supporters of the bill. And the question is, will this mandate at some point some legislative change, which is always a problem, especially since the session is already unfolding? Will this take some sort of agreement for us to modify all this? But in essence, what we presented to you as members of the commission this week is in essence 3 alternatives that we discussed with the individuals at this meeting. One is the timeline as it currently stands. The other is a timeline where a final report is issued not by December of 2024, i.e. the end of this month, but in essence is issued in June of 2025, which is when the commission sunsets. So putting in a 6-month time period there for us to continue our work. The third option that came out of our discussion was actually moving back even further towards December of 2025. Now, I will, if for those of you who have the copies in front of you, you can see that the 3 proposals that are put out, which is current timeline, the other one noted as report due December, the other one put out as this report due January. Perhaps the key feature is the last page. We put a lot of detail in on what should be accomplished on a monthly meeting, but the last page of each of these gives you in this short, succinct fashion of when things need to be due based upon the modified timeline. Part of the reason that we began discussing this idea of June versus December is what impact do we want to have? And that came out very clearly in our discussions with these individuals at the Friday meeting, which is if we issue a report in June of 2025 and the legislative session doesn't occur until the following year, is that 6-month gap a gap time where either, from an optimist perspective, we're out there rallying everybody? Or is that now a quiescent period where perhaps the world begins to change and the final report isn't as pertinent, isn't as in people's face as we'd like it to be? These are difficult decisions to make, but we do want the commission to opine on this. And leave it to the commissioners for us to figure out the pathway with the legislators of how we want to induce this change. But right now, based upon the recommendations we've had from a small group of people and others we've talked to, we are in support of not sticking with, that is the commission, the co-chairs, right, are advising not that we not necessarily stick with the original timeline, that we look at one of the 2 other alternative timelines, the June or December timeline. And at this point, I'd like to open this up to discussion. We'd like to have a motion put today so that we can actually have more vibrant discussions with decision makers at the political level.
With the
And
caveat,
I'll put it back to the chair since you're chairing the meeting.
You go
So
ahead and do that first.
end of my, okay.
it was just with the caveat that we're going to get as much as possible into an interim report just before next session.
Right, if at all possible, I mean, if you look at, so one of the options we looked at is because the legislation says that that a final report needs to be issued in December of 2024, we issue something that's not called the final report, right, in time for the next legislative session. And that certainly can be discussed depending on our work, progress, right, today, which is that we don't just bypass the next legislative session, that perhaps something is issued, whether it's a report on part of our assessments, whether we call it, the legislation demands a final report. And really the discussion today is not how we fill in the gap. We can discuss that in the future, but in essence is when do we issue the final report that the current legislation demands of us? Feelings. Got feelings from the commissioners.
The legislation, I can't recall, identified who's going to be drafting this report.
Well, it's on.
And if not, how do we think?
Right. I mean, part of this is, it goes back to both the funding and staffing component, right? We are in the midst, and this will be reported later, is, we're trying to obviously through a relationship between MACHO, as you've heard in the past, between MACHO and the CDC Foundation to be able to, one, find the funding and find the personnel that would ultimately be staffing not only our work groups, but in essence, coordinating what would be a final report. In the midst of all this, we are talking about many other options, right? Amongst the options there are components of a final report that would be to some extent descriptors, right, of what's going on in the state of Maryland. You know, one option is for us to bring in higher level students from our academic institutions with proper mentoring to begin that work, right? Begin filling in what would be a skeleton of a report, using students to be able to do the research of the current status of public health, that being monitored by us as a commission, by the co-chairs, and by academic leads at the academic institutions that have such students, right? So my sense is we can begin writing a report next week, potentially, right? That doesn't fill in the gist of the report, and the gist of the report really is going to be what are the specific recommendations for us to improve the public's health, right, and public health as an entity within the state of Maryland.
So I know at our last commission meeting, we did have some quite extensive conversation about the challenge of the current timeline that's been legislated. Yet we moved forward and adopted some concrete steps we can begin implementing with the assumption of that timeline. So again, we're asking for the commission's vote, decision, discussion around some of the other two timelines so that we can restructure some of those intermittent steps that the work groups milestones along the way.
So Lauren, I want to thank you for the work that went into creating the three options with the timelines to make this easy. I don't know. So I have a question about the two, either I guess December or January.
Or June or
Yes.
June or December.
By extending it an additional 6 months, December to June, what is there anything substantively you think that we'll be able to accomplish to be able to get it into the report that would merit another 6 months extension? B, going back to what you said about legislatively a 6 month gap, does anyone else can opine about the pros and cons of that? Because I do not have that experience to say whether or not having 6 months time to go out and peddle your report, or if you're turning around within 2 weeks of legislative session, I seems like I don't know how that works.
Yeah, I mean, that's really a discussion. It came up again, and we needed to sort of put in front of the commission, right? We were kind of looking at this June, and then, you know, as part of our discussion in Annapolis on Friday was, well, you know, it's going to be sitting around for 6 months. And that has the ability to do one of two things, in my view. It has the ability to flourish and blossom. And for us, no longer a commission, because the commission would end in June, to be able to go out there and in essence talk it up, even though we're no longer commissioners. So that's, again, the optimist viewpoint. The negative viewpoint is all of a sudden we issue something and it's sitting languishing, right? So the question is, do we have it in us to continue to fight, you know, for this report, even though 6 months later, who knows what the world is going to consist of at that point, and it may not be all timely. I would think that most of the recommendations, again, I'm projecting to the point of having a final report. Most of the recommendations would be the same recommendations in June of 2025 as they would be 6 months later. But what about that 10%, 20% that in essence is no longer applicable? Is the 80% or whatever factor, I'm making this up, right? Is that good enough for us to say that it's cleaner for us to issue a final report at the time that the commission sunsets versus trying to do an expansion of the commission, right? Because there's two lifts in the midst of this.
But just to be clear, like, our most, like, we want to influence session. We want the report is a tool. Like, who cares about the report, right? It's a tool to influence, like, the session and the rate setter, ultimately, right? If we want to actually get something done. And so, like, the December interim report is really important. So, because session is then, and then the next one is like reinforcement. It's reinforcement, right? It's cavalry, I guess. But I mean, if we think, and Fran and Nilesh, I'm sorry, but you guys know how this stuff works, right? And I mean, maybe you guys have.
Well, I think that's a really good point about how, regardless of the final report, how important the interim report is, needs to be the next year's session, right? So let's think about that, because that's not something to slide over. In your discussion last week, First of all, let me just say that I think as a group said last meeting that the original timeline is not sufficient to allow us to do a report that has the scope and the depth that we all anticipate, that we are all working towards that. And you come saying we're close to Indiana's, so we kind of discount. So we're looking at the two, right? And so in your discussion on Friday, what's the legislative mechanism for A, defer until sunset, or B, push it out? Are there two different legislative moves that need to occur? Because, right, I understand the urgency of getting this settled today, I think, because
The
something
urgency,
needs to go
right.
back to Annapolis.
So
okay?
the answer to
So
that,
what is it that we
Right.
need to do?
right, and that still needs to be fully determined, right? Because we did not necessarily have the people in the right room to determine what the steps are.
Okay,
To
so we
some
don't
extent,
know.
Senator Kelly, who's not present today, right? Is she on or not?
For staff.
The staff.
Her staff is on. So we had a staff member of Senator Kelly's office. As you know, Senator Kelly is not only one of the sponsors of the bill, but also is a member of the commission. I think staff was going to brief her on Monday, and we've not heard the results of that briefing in terms of the pathway ahead on that. We've been advised by others who have interest in the bill that there's several approaches on this, right? Do you need the legislative fix versus do you need an understanding
That's
that
exactly
the
the
commission is
point.
coming
That's
up, right?
exactly
Because you know
the
how,
question.
you've lived there, right? You know how these things work, so that's what we have to determine. What I think we want from our perspective is saying that the commission advises that this timeline is what fits into our mode of thinking, right? As a step that right now. We don't want to waste this meeting not having a pathway ahead from the commission's perspective. Allow us then to take it back and say, what is the necessity? Because this has got to take place in the next week plus, and maybe it's already late because legislative ideas already have to be put into the mix. There's I forget which date. February 5th is when legislative changes have to be put in. So what we're trying to do here today is not having the right answers right now is trying to figure out what the pathway is. But what we're trying to do is to say that the commission has looked at these options and here's what the commission feels most comfortable with.
And just to provide context to people that have attended the previous meeting, as it stands as of today, we do have a motion that we voted on, which is the timeline that ends in December, while we continue to seek the guidance of the legislators for an extension. So that's where we're starting from, and then we have these two propositions based on all the discussions that we've had, and part of the meeting we had recently where we are.
So I'll bring up a few points. One, in light of our staffing and funding question, I am concerned about increasing the length, increasing the amount of funding and staffing time. Second is, I think it's always good to sprint as fast as you can. It's done. It's just hard to, the longer it takes, the longer it takes. It's kind of it. Yes, you need some minimum amount of time, but I would say June push. And the third is whatever advocacy we're going to do is, even if it ends in December, there will be a commission. There will be advocacy that needs to happen. So everybody hears and beyond is going to need to be engaged in that process, that push, that engagement. For my take, at least, you want that extra time to be able to plan to be able to report. It's done in June. You plan it out as opposed to in December. You can still do it. You're just crashing into session really hard.
So there were a couple points, and to bring it back to what Chris was mentioning, again, the report that would come out December 1, 2024. So the advice, of course, has been that we do issue some type of report, regardless of whether we're looking for a final report in June 25 or December 25. It's still good for us to issue something that can be meaningful for the next legislative session. So I think if we are to produce something that's meaningful for the next legislative session, what we end up doing is really focusing on assessment and some preliminary recommendations, right? Because an additional time, right, whether it's June or December 25, will give us more time to have a robust assessment, which is really what we're trying to get to. We're trying to get that robust understanding of our governmental public health infrastructure and impact on the public health system overall. So I think if we have one of those two extensions, we're still coming out with the report for next legislative session. The other piece is that if we do come out in June with a final report, June of 25, one of the comments, of course, I think you mentioned, Boris, is that it might be a little too far ahead of when legislative session is and lose the interest or attention of elected officials. Now, understanding our report isn't only about policy, right? Our report is also going to be recommendations that can be implemented at a non-legislative level, right? But there is a concern, as that was expressed at our discussion on Friday, that putting it out in June versus waiting until December 25 we would lose some of the steam of the report.
Any further comments, discussions, and then I would love somebody who has the feeling towards one of these pathways to introduce a motion. Or I can as a co-chair, but I'd rather hear from other commissioners.
Questions, guidance to push this forward faster. It's a motion.
He was mentioning June. Is that
June. I'll move it.
June of 2025.
June 30th, 2025? Any second on that motion? Okay. All right. Any additional discussion beyond what we've already had? Okay, and we'll move to a vote. So all those in favor in the room, if you could just raise your hand so we can take account.
Again, only commissioners vote.
9. And then Alan, if you want to support the June, if you could put your thumbs up. Thank you. All right. Okay. Any opposed to a June 2025 deadline for the final report? One in the room. Anybody? Or Alan, you voted aye for that. Okay. Any abstentions? Okay. So that's 9-1 on that motion. And are we accounting for all commissioners? We have 10.
Okay,
So that motion carries.
Thank you for
Thank
good
you.
discussion.
Thank
So
you.
I do want to just say that I would like to reserve the right that as we, when and if we get more information, that may change, right? So we may find out a lot of things later on that we may need a little extra time to be able to still issue a report, but we may want to actually make a little bit of change because we got all this information right there.
Right.
Makes
Good point.
sense.
Yeah.
Rather than dropping.
Right. I think, again, Madam Chair, allow me to sort of intersperse here with one last time on this, is that right now, the motion as it stands allows us to plan, right, our meetings and to advise the work groups on here is the expectation and the timeline expectation. Again, we will go back to the legislators to be able to sort of reaffirm that in whatever mechanism that we're going to be covered on this. That being said, however, obviously we're going to be assessing throughout this whole next year, right, of where we are and where we stand. And at some point, hopefully not, but it could be in September, we're sitting around here and somebody says, this is not doable, we're behind, or optimistically, damn, look at us, we're way ahead of schedule, right? So what we're trying to do is allow us as a commission to be able to have a sense of what is the pathway at this stage in time, and that's what we're going to be implementing. So it's a good point. Is this set in stone? The reality is set in stone for now until we break that stone. I love speaking in metaphor. I'm not sure what that means, but
Thank you. Thanks for handling that discussion point. The next item is our public meetings. So if you recall from our last meeting, legislation requires the commission to host 3 public meetings. At the last meeting, we presented 4 options hosted by local health departments in those regions. So the 4 options were the Western region of Maryland, represented by Washington County Health Department, the Eastern Shore, represented by Talbot County Health Department, Southern Maryland, St. Mary's County Health Department, and Central Maryland, Howard County Health Department. We voted to approve those 4 as hosts for public meetings and regions. In the discussion, we also identified a desire to have a second Central Maryland site. And at that time, the direction was given to the co-chairs to approach 3 health departments, the Montgomery County Health Department, the Baltimore City Health Department, and the Prince George's County Health Department. So after consultation with those 3 health departments, they are all interested due to what is feasible from a timeline logistics perspective. The 2 options that we have in front of you today are Montgomery County, and Dr. Keisha Davis, the health officer in Montgomery County, is here today in the room, as well as the Baltimore City Health Department. So it's up to the commissioners to decide where you would like to move next.
Describe what exact counties are considered Eastern Shore, Southern, Central, and Western?
Sure, I don't have that memorized, but I can say for Southern Maryland, the 3 Southern Maryland jurisdictions are St. Mary's County, Charles County, and Calvert County. For Western Maryland, it's Garrett, Allegheny, and Washington. Eastern Shore, I believe there's 8. And Bill, if you're on, you're welcome to chime in and list them all. Or not. But there's 8 on the Eastern Shore, Talbot County, Wycomico, Worcester, Kent, Queen Anne's, Somerset, thank you. Dorchester, thank you. Roger. Am I missing another one? Who's missing?
Caroline.
Sorry if I'm offending any of you.
Cecil.
Cecil.
And Caroline.
Caroline, thank you. Yeah, Cecil was considered part of Central Maryland. And then the rest unnamed are part of the Central Maryland category. If you would like to name yourselves, feel free.
Well, so that's where I'm coming from. So the greatest population is in the central. So how would it be broken up? Breaking it up between Howard, Baltimore City, or Montgomery?
Right. So the requirement from the legislation was 3 public meetings. It didn't even say dispersed across the state. We decided we wanted to have regional representation because of interest in gathering public input. At the commission meeting, the direction was to approach those 3 specific ones, Prince George's, Montgomery, and Baltimore City. So that's where we put the effort, and there was some discussion around the whys for that. So it's not, the strategy is not trying to pick one northern central, one southern central, or eastern central, or western central. Although if that's what the group decides to decides to make a decision on that geography as a reason, then that's up to you as a commission. But we don't have a strategy that's focused on geographic or population distribution across the Central Maryland region.
I'm just thinking from this perspective of hosting the meeting, right? Right now, Central is a large swath of the population and potentially have a lot of people that I'm just curious as dividing it up such that you have a meeting wouldn't be productive, but a meeting that's conducive to getting the input that you want to get. That's
right. Yeah, great points. And if it's up to the commission. If the as I said, the minimum is 3. If the commission chooses to do more than 4 or 5, that's up to the commission to decide. Keeping in mind what our timeline is, and that this is part of the assessment period of time. And as part of the assessment period of time, we want to make sure we can fit those in. All right. Any motions?
Is there any? Was there any? Everyone expressed interest of our 3. Was there any rationale given for why? Or I mean, it's hard to make it. I mean, I would take any 3. I'm agnostic as to which, so I don't know.
Sure. So Baltimore City and Montgomery County both expressed that they would be able to hold the meeting in the time frame of the assessment phase for this commission, and do so in a way that allowed for virtual participation as well as in-person participation and so forth. So again, the direction was to have a 5th meeting, right? And to have one of those 3 health departments, of which 2 are available to host.
So you're saying Prince George's County is not available? So
Right,
it's not-
they were interested, but it just didn't work out from a timeline and logistics perspective at this time.
So we could either entertain a motion to have both. So that would,
Sorry, can I ask an operational, because Howard is willing and we have the space to host. One concern I have about hosting public meetings per the Open Meetings Act is hybrid format for the public. And mechanisms for the public to give input in this hybrid, in a hybrid format. So I don't know if that's, I have concern with having done that versus public input in person and in written testimony similar to the legislative. So I just have concerns about it. It's not worked well when public input from anywhere is coming in for the Open Meetings Act. That's not concerned.
Is this, I mean, and, you know, like, this might not be the way things are done, but is it reasonable to delegate this to the chairs to negotiate with the county health commissions?
After you choose, and if everybody votes on that, sure.
And interested other commissioners?
If you want to make a motion to that effect, if everybody agrees. Sorry, being a commissioner.
I mean, it's,
Were you done?
yes.
So I know we have Dr. Davis here. Do we have someone from Baltimore City? Okay. Well, Dr. Davis, can you just provide us with racial and ethnic background?
So Montgomery County has about 1 million residents. We are about 40% white, and then the split Latino and African American now. But for all intents and purposes, I think some of the interesting things about Montgomery County, it is perceived as a rich county, but we have a lot of poverty, and so the socioeconomic disparity that exists within the county is quite great. And so that there's an example to see how we have some health access programs. The health department is basically the way that we were thinking about this visit. If people are ready to come, Montgomery County is a little bit different in terms of how public health is carved out of the health department, but this would really be so. For example, behavioral health isn't within public health per se, but it is within health department. I want to expose you to the entire health department, so and kind of see how that's integrated. And we are a whole county.
And just a quick follow-up, thank you for that. One of the things that, as I recall, that we talked about at the last meeting, specifically with Montgomery County, was the making sure that we are involving our residents from English is not their primary language. So have you all hosted public meetings like that, and how have you navigated some of the challenges that have been put forth in regard to getting that input?
So we do have simultaneous translation when it's available. So we have over 130 different languages represented in the county. So that is our experience to, our most common non-English language is Spanish, but we also learn French and other languages.
Discussion points, thank you. Any direction from the group in form of a motion?
I'll just say, what the difference to me would be on this go. Montgomery County is great, literally a stone's throw away from the city. Panera Bread is in the city. I'm not too sure if that's going to make a significant difference, because when you're in the urban county, it's the same makeup as the city. But I may not be thinking about that the right way, or maybe other thoughts about that. I don't know if it makes a significant difference based on where we are. We'll be actually in the city proper for make a difference. It's pretty. It
Eastern Shore in December.
That was already. Were you in the process of making a motion?
I mean, my suggestion in the interest of trying to like get this done is to let to delegate our authority to the commissioners to talk and make sure we have a willing partner and appropriate facilities and rock and roll. Yeah.
So just to clarify, did you mean to the commission co-chairs?
Delegate to the co-chairs from the commission if that's.
Thank you for that motion. Is there a second? Okay, thank you. Any discussion on that motion? Okay, all in favor? Thank you. Okay, Alan virtually, and if any other commissioner has joined us virtually. Okay, any nays? Abstentions? All right, motion carries. Thank you. We'll do that. Thank you very much for getting that table. Let's move over to the last item for new business. We, at the last meeting, presented a roster for your approval of the co-chairs for the 5 different work groups as well as members of the work groups. We appreciate Bill Webb was serving as the co-chair for the Data and Information Technology Work Group, and due to some unforeseen needs with his health department has to step away from that role. We appreciate Prince George's County Health Officer, Matt Levy, who is a current member, and the other member of the work group, who is a health officer in the Data and Information Technology Work Group, has offered to be the co-chair for that work group. So we're presenting the revised membership roster and co-chairs for the work groups to your attention. They're in the meeting materials. And for your review, discussion, vote, motion would be great. Anybody wants to make a motion on that? Make a motion for this. Thank you. Motion to adopt is on the table. Is there a second? Okay, thank you. Any discussion on the membership roster as revised? All right. All those in favor, please raise your hand. Thank you. Okay. Alan Twig. Great, thank you. Any nays on that? Any abstentions? Okay, thank you. Motion carries. All right. I'm going to shift over. First of all, thank you very much. That business is very helpful. We're in a pretty critical stage of our commission right now, very formative, critical stage that's going to be setting us up for the next several months. And I just really appreciate all the wonderful engagement we've had from all of you as commissioners, from all our work group members, many of whom are here in the room or on virtually. Thank you very much. This is an incredible process. It's going to have an incredible impact for Marylanders, every single Marylander. I really, truly believe that. And I just very much appreciate all the time that's been put into your service so far. Dr. Lishniak is going to introduce our first speaker.
Yes, thank you, Mina. Last month, I had the pleasure of introducing Bob Stevens, who gave us an overview of local public health in Maryland. This month, I have the pleasure to introduce a commissioner of this commission, as well as a dear friend. Nilesh currently serves as the Deputy Secretary of Public Health Services at the Maryland Department of Health. So he is Department of Health person on our commission, a key position. I've known him for several years. I find him to be a pleasant person with an incredible smile, right? Even under the most stressful of circumstances. If you want to get your spirits up, look at Nilesh and he gives you a good smile, even though the world may be falling apart. It's an incredible job in Anne Arundel County from 2019 to 2023. Obviously, that was through COVID. Dealt with issues of gun violence, community health outreach to advance health equity. He's also worked at federally qualified health centers, including within Baltimore and Unity Healthcare in Washington, D.C. He's a physician trained at SUNY Downstate in Brooklyn, New York, a triple SAS fellow at the National Institutes of Health. And he's smiling already, so he's making me really feel good. He's going to give us an overview of the state public health system here in Maryland. Critical to this is just a reminder to all commissioners, right? Part of what we're all about is If you think you know something, it's good to review it, right? We're not going to give tests to the commissioners, right, about what did you learn last month about local public health, nor is there a test today. But for us to function in our jobs, all of us have to take a deep dive into understanding the current system as it exists. Last month's presentation is on the website, right? So you can refer back to it, certainly as we're making decisions, and this one will be as well. So don't expect everything. We don't want to put the pressure on your shoulders because it can be a complicated scenario, but we welcome the last presentation. Thank you.
Thank you. I thought longer than I thought.
Well, but I didn't praise you too much, and the smile, it's like last time I talked about cross-country skiing in Garrett County, right? That was captivating. It's the smile, buddy.
Well, I'll tell you, this is my favorite place to be. I live literally around the corner. That's the Giants I can shop at. So I love being here. Thank you, Rich. But more importantly, thank you to the commission and to the co-chairs. Do you want me to control it, or should I just tell you slide? Or just, I don't even know.
Just say slide.
Got it. All right. So as we were putting this together, and I want to highlight a couple of people. Stephanie Juzzi, where is Vanessa? Behind me. Hi, Vanessa. Vanessa Lamers. They both work in my office at the Department of Health, and they were. What you see here is a product of their efforts and work. So I just wanted to highlight them before I get started. I'm going to offer you an overview here. We could obviously go into depth on any of the slides, any of the sections here. This is to just give you a sense of what is happening in public health infrastructure. Next slide, please. Next slide. So our focus at the Maryland Department of Health is to improve the health and safety of all Marylanders through disease prevention, access to care, quality management, and community engagement. And I want to highlight particularly the prevention piece. I always say that one of the beautiful things about being in governmental public health is we are focused on prevention over a long time scale, right? Most uniquely amongst everybody is we get to think what's going to happen in a decade or two. We don't always get to live that every day, but that is our goal. Next slide, please. Sharing our vision, mission, and core values. Vision is lifelong health and wellness for all Marylanders. And our mission, all individuals, families, and communities in Maryland to achieve the best possible health outcomes through equitable access to a world-class, high-quality health system that provides whole person care and treats everyone with respect and compassion. And embedded in that is our core values: courage, collaboration, and compassion. Next slide, please. So that's really tiny. Hopefully you have the slides, but it's meant to give you a sense of the structure and organization. The one thing I'll say about this is that our Secretary Laura Herrera Scott, next one, we hope, yeah, we hope. But she oversees a department where there are 5 different units that are led by deputy secretaries, and 2 other units, one of which is led by Neil here as one of the commission members here, minority health and health disparities. Next slide, please. So I'm going to give you a brief overview of those the deputy secretaries. That is, of course, our secretary. And the office of the secretary oversees, obviously, the entire department, but also directs policy, supports all the work, all the operations work throughout the department, and make sure that we are integrated with the governor's office and the legislature. Next slide. Oh, I didn't know I got moved up here. I thought I was at the end of this list. That's me. We're going to skip me because we get to talk mostly about what I oversee for the rest of this talk. Another piece of this is the Developmental Disabilities Administration, DDA, as we call it, and that's Marlena Hutchinson, who is new to the role as of January and came over from the Medicaid side. They work with people who have intellectual and developmental disabilities to get support and resources so that they can lead good lives. It's a state agency that really, we pay for services in communities through a variety of mechanisms to make sure that people are living their fullest lives. For a sense of scale, it's roughly a $1.5 to $2 billion unit from the department. Next slide. Third unit is the Behavioral Health Administration. Lord, unfortunately, could not be here today, but she's another commission member. Behavioral Health Administration has oversight responsibility for publicly funded inpatient and outpatient behavioral health services, and supports to help keep individuals with substance use disorders and mental health conditions leading their best lives. A lot of that work happens on two tracks. One is really focused on the public behavioral health system, but then there's also policy and oversight as to the large texture of our behavioral health service delivery in this state. Next slide. Fourth is our healthcare financing and Medicaid administration, is Ryan Moran, who I had the pleasure of knowing for many years prior to now sharing a wall with Ryan. The Medicaid administration obviously administers the state's public health insurance program, Medicaid, where a lot of the policy making is done as to how we are addressing a variety of issues through healthcare financing, through health insurance. Next slide. Last but not least is our operations administration, Brian Rose, who oversees two main pathways. One is the operations that support the department, things like HR and procurement. I bring those two up specifically because we are going to have a great interest in that. But then the other piece of that is the Maryland Department of Health healthcare system. We operate, if not the biggest, one of the biggest healthcare systems in the state. 11 facilities around the state. They're focused on providing services to individuals with behavioral health conditions, chronic health conditions, and then residential treatment for adolescents and individuals with developmental disabilities. It is not a piece of the department that gets a lot of attention, but it is good to note that it does exist. Next slide. Actually, you can go two more forward. This is just a summary of what, talk a little bit about our funding and our budget. So in 2024, our funding for the department is $19.6 billion. We represent approximately 1/3 of the state's budget. And you can see here comparison of how much of these funds are general funds from the state, how much are federal funds for the state, and those are the two largest categories of funding for the department. Next slide.
Federal funds shrinking.
Go back a slide. That's a good catch, and that's actually mostly due to COVID funds going away. I'm not going to go through this slide. I left this here for you to look at later. This breaks it down by the administrations that I just mentioned, the 5 administrations, and what are the relative amounts that they get from general funds, special funds, federal funds, and reimbursable funds. For scale, Medicaid is about $14 billion. Behavioral health is about, you can see right there, but a couple of $1 billion. Developmental disabilities, about $2 billion. Public health is actually the smallest of the units at $850 million. Next. This slide, the formatting was a little off, but this goes into a little bit more on the funding for public health services. And once again, I mentioned that we're about roughly $850 million. Both of those funds go to our Prevention and Health Promotion Administration. That is the unit of public health services that probably are the things that you think of as sort of your core public health services. We'll of course be diving into all of these units as we're going. Next slide. Again, provided some additional detail for you to take a look at, but I'm not going to dive into detail on federal stimulus dollars. But this gives you a sense to Chris's point about what's happened with some of the stimulus dollars and what's happened with COVID dollars and how that's shifting and adjusting. Next slide. So I'm going to dive into what we do for Public Health Services Administration. And there are a lot of people here. Fran's going to keep me honest here, right? Next slide. So PHS administration, our goal is to build a healthier Maryland, right? Our goal is to is to build a Maryland in which every Marylander experiences optimal well-being. So we're responsible for these range of services that I'm going to go through, but that includes infectious disease control, chronic disease prevention, environmental health programs, maternal, child, and family health services, food safety, healthcare quality, vital records, chief medical examiner, anatomy board, emergency preparedness, and then overseeing the 24 local health departments. Next slide. Our goal is to work together to promote and improve the health and safety of all Marylanders through all of the items that I mentioned. And key to that is making sure that we are collaborating, that we're data-driven, that we're focused on equity, integrity, leadership, and fostering innovation and excellence. And I think I want to highlight that last piece is that there is tons of innovation at in the department, and it's probably the thing that keeps me the most excited. It's hard to get it out into the world because there's so much going on all the time. And I think that's one of the things that I'm hoping that we can do here together is to be able to focus our energies and really look at how we can innovate in public health and take us to the next level. Next slide. One of the keys is the commitment to equity. I mentioned Camille is the director of our Minority Health and Health Disparities, Office of Minority Health and Health Disparities, and a core part of driving us and our work forward to make sure that we are not just talking about equity, but working on achieving it and getting there. And that means that we are focusing on improved access to resources for Marylanders, better assessment of and consolidated efforts to promote interventions for at-risk and high-need populations, critically disaggregating data for socio-demographic and geographic categories. I'm going to sit on that for a second. The thing that I have found that is really helpful in advancing equity is to be able to share data that shows what the disparities are. It is very hard to aggregate all of the anecdotes that we, when we do this work, live through, but that data does cut through and does lead to people really seeing the need for why equity is important in the work that we do. And the last, certainly not the least, is collaborations to break down barriers created by the social determinants of health. And I think that's a core operating principle, is that we can't do this work without the communities or the populations or the groups that we are working to support and improve their health. Next slide. That's just a listing. For all of you who are eager and are going to go back and look at this, we're going to go through each of those units in a second. So next slide. Local health departments. I am not going to go over all of this because Bob did that last time. And so you're only going to see a couple of slides in here. But local health departments are really, I think, from having served as a health officer for a number of years and now being in this role, really they're the instrumentalities of actually getting public health work done across the state. They sit at the unique nexus, and I think what's really fun about local health, at least as it's situated in Maryland, is the ability to take the inputs from the state, from the county, and from your community, and be able to integrate that in the plan to improve health across that county. Next slide. And of course, a listing, and I will not read 24 counties at you. Next slide. So the first unit of the public health services that I want to mention is Prevention and Health Promotion Administration. That is, and I started off by saying that this is the unit that is probably what is thought of, or at least the services that they oversee are thought of as core public health services. Next slide. There are five units within what we affectionately call FIPA: maternal and child health, environmental health, cancer and chronic disease, or infectious disease epidemiology outbreak response. And then carved out from that is our Infectious Disease Prevention and Health Services Bureau, which is really focused mostly on HIV and STIs, and with a specific focus on that HIV and service delivery and insurance program. Next slide. One more. So our Maternal and Child Health Bureau is focused on birthing individuals and providing services to birthing individuals and families to support a lifetime of health and well-being. And these programs span from pregnancy, birth support, infant infancy, childhood, adolescence, and preconception care. Next slide. So there are a lot of programs in the maternal child health care. You're probably familiar with many of them. Things like WIC, things like our newborn screening and follow-up, early hearing detection and intervention, our maternal infant early childhood home visiting programs, school-based health center programs. I think that the important thing to think about and remember here is that this work is really focused on how are we supporting these families with young children, and how are we making sure that we are giving them the best start to life and improving their health back. And I think that the key here is that we know, right? The earlier we provide services and intervene for those who need it, the better the outcome. Next slide. The Environmental Health Bureau. It works to ensure all Marylanders have access to clean, healthy, and safe environments in their home, communities, and across Maryland. And let's go to the next slide. I want to highlight some of the programs that we have. Our Environmental Health Bureau has a range of programs. Some of them are on the more regulatory side. Things like our permits and licensing, our food protection at the state level. It's mostly for food manufacturers. At the local health department level, it's focused on restaurants, and food service establishments, recreational safety, things like youth camps and pools. And then, of course, we work in partnership with the Maryland Department of the Environment on things like well and septic permitting. But we also have other programs that really focus on other environmental effects on health. So things like asthma, our asthma home visiting program, and our violence and injury prevention programs. Things such as child safety seats for cars, rape and sexual assaults prevention, and other types of violence and injury prevention programs. We heard about the governor's new push for addressing gun violence as a public health issue. We will see how that all lands and how that shifts. But right now, that is really a core part of the work that we do. Next slide. One more. So our Cancer and Chronic Disease Bureau works to improve the health of residents through public health initiatives, really focused on cancer, diabetes, cardiovascular disease, tobacco use. We should add cannabis there now as well, and oral health to improve their health outcomes across the lifespan. So some of these programs here are really focused on in cancer. There's a lot on cancer screening, diagnosis, treatment, prevention. Some of this is funded through general funds, federal funds. Some of it is cigarette restitution funds. A lot of this work is actually focusing on filling in gaps in insurance. So folks who are either uninsured or unable to afford with insurance access to this cancer program, cancer screening, diagnosis, and treatment, or we were able to fund those services. And then some of it is what you might think of as, our core public health services, education, prevention programs, data, that kind of. Next slide, please. Our chronic disease prevention and control unit focuses a lot on diabetes, hypertension, obesity, food security. All of those are interconnected, and there's a lot of work there to look at how we're doing that. The data, we struggle along with every other state in the country on addressing obesity, addressing diabetes, bringing those rates down. I think one of the challenges that we have and we see is we need to do things quite differently if we're really going to get traction on really prevention of these issues. And then last, there's the cognitive health program. So really an emerging focus on Alzheimer's and related dementias. And what are we doing in partnership with the Maryland Department of Aging on identifying that and addressing it? So you'll be seeing much more about that. Next. Oh, I'm sorry, yes.
So just like there's a ton here.
Yeah.
Like if you think about the budget, most of it is Medicaid, literally paying for hospital services and physician services and behavioral health is $2 billion of 20. How much is going to this stuff?
So overall to public health services is about $850 million. For the prevention health promotion specifically, it's about $580 million or so.
Is there, do you guys as like leaders of this, do you have like a dashboard or something that says this is the stuff that we're investing in now? Here's what's really working. Here's what we're experimenting in. Here's what we're stopping.
So that's one of the things that we are working to develop. So we have a lot of, I'm going to soapbox for a second. We have a lot of process measures, and one of the issues we have in public health is that a lot of the interventions have long-term effects, long-term, but it's harder to see outcomes in the short term. The question is, how are we making sure that those medium-term, short-term measures that we're looking at are really truly representative of effectiveness? So we are really beefing up our ability to say, okay, what are our programs that are really effective, and how do we expand them? And then what are the ones that are not as effective? Getting our back. There is more coming.
Is that part of what we're doing, is helping to promote movement towards that?
I'd welcome any help in that, yes. But that is one of the things that we are focused on. The secretary is focused on that throughout the department. And I've certainly focused on that for public health. Next slide. Tobacco prevention and control. A range of programs, as I mentioned, there's different funding streams for this. Maryland Quitline, our statewide local public health initiatives. We have youth prevention programs. We have retailer inspection programs funded through different mechanisms. And new in the past year is our Cannabis Public Health Fund. With the implementation of adult use cannabis in July, part of that legislative requirement was that some funds go to the Cannabis Public Health Fund to address both safe use or safer use, I guess, and also potential youth use as well. Next slide. And oral health, another core piece of the Cancer and Chronic Disease Bureau, looking at oral disease injury and injury prevention programs. Two of the biggest programs we have are school dental sealant programs and our fluoride varnish program. We continue to invest in that and look to expand that. Water fluoridation, as I have learned, there's far less fluoridation going on than I thought there was. And then lastly, of course, our oral cancer screening and public health. Next slide. And lastly, this is another program, our Maryland Kidney Disease Program, that I like to think of as the Insurance Life Program. It helps fill a gap for people who are either uninsured or unable to manage their payments who are insured, for folks with needing chronic maintenance dialysis, renal transplantation, or other fees and costs associated with kind of chronic kidney disease. Next slide. So I mentioned that we had two units. One is the Infectious Disease Epidemiology Outbreak and Response Bureau. And it's probably best to think of them as all the infectious diseases except HIV, sexually transmitted infections, including hepatitis B and C, which is in the other unit, which I will talk about shortly. So this group coordinates a lot with local health departments and also with our federal partners, CDC, FDA, USDA being the main ones, but also a lot of coordination with our academic health partners as well, as we're monitoring all sorts of infectious diseases throughout the state. They have led the efforts on Mpox, whenever we have things like measles as they come up, things like our malaria case, you name it, whenever you see an infectious disease in paper, that is in this bureau. Next slide, please. So a lot of the work is really when you see it as the tip of the iceberg. There's a lot of data surveillance, tracking down case and outbreak investigations and response. The greatest thing that happened to them in terms of people understanding what they do was COVID. All the tools that we did during COVID that were visible, things that our infectious disease epidemiologists have been doing for decades. Next slide. So this unit really focuses on sexually transmitted infections, including HIV, viral hepatitis. Obviously, syphilis is really in the news as well. We're seeing increases in that, and it's their focus is really on meeting people where they are. They do a lot of work on ending the HIV epidemic. Next slide. I think you're probably jumping ahead a little bit. A lot of work on ending the HIV epidemic. That's a core part of why they do a lot of community engagement. I would say they're probably one of the leaders within the department in terms of community engagement, but also really thinking flexibly about how to take all the dollars that we have around HIV, around STI prevention and treatment, and how do we build capacity, build technical assistance so that health departments, community organizations can do this work. How do we build clinical quality improvement initiatives? And Chris, to your question, I think that this unit probably does one of the better jobs in terms of looking at our data, looking at where our efforts are going. Are we getting the results we think we should, and then shifting as is needed. Next slide, please. So now I'm skipping to, that is the end of our Prevention Health Promotion Administration. We could probably dive into each of those elements and spend another 10, 15, 20 minutes on each of those. But I want to give you an overview of all of the other units that are within public health services. And while what was in the Prevention and Health Promotion Administration, a lot of that work, right, happens not just at the state level, but also happens at the local health department level. What you're going to see next generally happens mainly at the state level, with different coordination responses across the state. So Office of Preparedness and Response has both pieces in local health departments, but is also partners with the Maryland Department of Emergency Management and each county's emergency manager. Our focus is on the emergency management response for health. And so that means making sure that they are really good at informing the public about health crises, but also coordinating responses as they come up. Great example is we have our coordination calls and coordination work around hospitals during the respiratory virus season to see where they are. They are leading that response in terms of making sure that all of the players are at the table and that we are ready to respond as needed when anything happens. Next slide. A range of programs, things like doing biosurveillance, that's particularly in partnership with the federal government, health system surge and planning, which I just mentioned. You know, we have these hospital calls, our hospital preparedness program, which is shifting to our healthcare preparedness program in our next iteration to really look at how our healthcare system is resilient to emerging challenges, our medical reserve corps, and then countermeasures to biologics, to nuclear accidents, weather disasters, a lot of that kind of high-level coordination across local, state, and federal partners. Next slide. Our Office of Healthcare Quality monitors the quality of care in Maryland's healthcare facilities, community-based programs, and it oversees providers in 45 different industries. Next slide. So a good part of their work is focused on kind of the big players, nursing homes, assisted living facilities, get a lot of attention, but there is a lot more to that. But a key to the work that they're doing is that they provide licensures to authorized facilities or programs to do business. Part of it is certification for Medicare and Medicaid reimbursement, and they are making sure that healthcare facilities are compliant with both federal and state regulations as is appropriate. Next slide. The Office of the Chief Medical Examiner is the statewide agency. So we have one Office of the Chief Medical Examiner for the state of Maryland. So it investigates every case, sudden or unexpected deaths due to injury, unexplained or suspicious circumstances, or not attended by a physician throughout the state of Maryland. And part of that is they have medical legal responsibility to perform these forensic autopsies and determine cause and manner of death, in addition to their public health role, which is identifying trends in injury, intoxication, infectious diseases. Their work is part of what we were able to identify fentanyl and even carfentanil. It's why they were starting to see that in their toxicology. So that has helped us, on the public health side, be able to address that issue. It's also a teaching and training institution. It is one of the few remaining standalone forensic pathology training institutions in the country. Next slide. So as I mentioned, they are responsible for forensic death care services to decedents and their families, and that means providing the autopsies, working with courts, working with police, investigators to as part of investigations into sudden, unexpected, or violent deaths, and of course training forensic pathologists. Next slide, please. Our Vital Statistics Administration has two divisions. One is health statistics, which compiles and publishes reports based on vital records, that are registered each year. For those of you who are familiar with it, sometime in the fall, typically, there is a large PDF that comes out that has a whole range of statistics for the prior year. Our goal is to digitize that and put it online so that you can actually access it whenever you want, not as PDF, but it contains information such as causes of death, the top 10 diseases, birth, and natal statistics, death statistics, life expectancy, and other vital health statistics that help paint a picture of the state of health in the state of Maryland.
The question right now, it's only available as a PDF, so as not user friendly to the public.
Not at this. It will not be that way. Our goal is by the end of the year to get that online, an interactive dashboard.
That's close to a dashboard. That's like the state of the health kind of state of health in the state.
I would say that it's probably less. It's less interpretive. It's more just kind of raw data, and we tend to take that data and I can use it for any number of uses. So I would think of it more as kind of like the backbone data.
Does it always stay the same year over year, or do you guys make changes to it?
The fields are fairly static. So it's not, we have many other data reports that come out, but these are really considered the vital statistics, and they're more in line with kind of federal guidelines around what vital statistics are.
Are they actionable data?
Most of it is not very actionable. It's much more in terms of painting the picture of what is happening, right? So things like birth rates, death rates, these are the top 10 or top 15 diseases that are the causes of death. A lot of the actionable data that springs from that or springs from other data sources. Be happy to share a link to this. Put it in. Figure out a way to share that. And then the other piece of the Vital Statistics Administration is our Division of Vital Records, which issues birth and death certificates and marriage certificates as well. Marriage certificates is the more recent times, in the past 17 years or so, and divorce verifications as well. So pretty much for most folks, this is birth and death certificates, and this is where our official register of that is. Next slide. We can go to the next slide. So our labs administration, this is our public health laboratory. The public health laboratory provides a range of laboratory services to support our public health efforts across the state. Our main lab is in Baltimore City. right abutting the campus of Johns Hopkins Hospital. But we also have satellite labs, one in Salisbury, one in Cleveland as well. And that's mostly used for our environmental health services. Next slide. So there's a range of services that are provided by the Labs Administration. Once again, a lot of the work the Labs Administration does is in partnership with both local departments and also with our federal partners. So a lot of infectious disease prevention, control, and surveillance testing is done out of there, particularly in partnership for more rare or dangerous pathogens. Newborn screening, there's the number, I believe there's 62 newborn screening tests at this point, all being done through the Labs Administration, environmental health testing, including new capacity for PFAS testing, emergency response, food, water, and consumer product safety. Just last year, we published a paper about yellow oleander. These weight loss nuts that actually caused a death in an individual, and found that they contained a yellow oleander, a substance that was, first of all, should not be consumed. Second of all, wasn't even aware, the manufacturers weren't even aware it was in there. So providing that kind of expertise is really what their function is. Next slide. Our Office of Provider Engagement and Regulation provides support for prescribers and dispensers to better promote professional education around best practices and innovation. And this is really around controlled substances. And there's two pieces to this office. Next slide. One is our prescription drug monitoring program. And this is a program that, as it says, monitors prescription drugs, and particularly controlled substances that are either prescribed or dispensed throughout the state of Maryland. Prescription is something you fill at a pharmacy. A dispense is something that you get. You get the medicine from a provider and you take it out with you. If medications are administered at that site, like in a hospital, you get a medication, that does not go in. The goal of this unit is really to focus on provider outreach and education around safe prescribing habits, and also to identify patterns or outliers from those patterns in terms of prescribing or dispensing practices, so that we can identify problems and address them. Next. And the other piece of this is our Office of Controlled Substances Administration, which provides controlled dangerous substances licenses to individuals, and permits and licenses to individuals who are authorized to prescribe, and also does a lot of work with with dispensers, manufacturers, distributors around making sure that we are aware of and preventing diversion and other issues around outlier work. Work a lot with pharmacies as well to make sure the pharmacies are up to date, and monitoring also where the controlled substance supply is, and that one of the core functions, and that it's not getting lost or diverted. Next slide.
What does the MHCC do?
The Maryland Healthcare Commission, that is if you don't mind, I'll get to that at the end, but that doesn't fall actually directly under the line of the Maryland Department. Our Office of Population Health Improvement works to really do a few things, works to transform our public health system through data and partnerships so that we can improve the health and healthcare delivery infrastructure, really focused on the workforce side of things. Next slide. Healthcare workforce is a core part of what we do, and that includes things like our loan repayment programs, our work on understanding what are the workforce issues we have, whether that's rural health workforce, community health workers, or other types of workforce. And there's more that we can talk about on that front. So focuses on local health department billing. This unit actually has a little bit of a kind of, here, take a few of these other items that don't fit anywhere else, things like local health department billing, those. But really, we are really crystallizing this area and putting a lot of resources and effort into here to really beef up our understanding of the workforce. And what do we need to do to invest in workforce throughout the state? Next slide. Or the State Anatomy Board. The State Anatomy Board is housed at the University of Maryland Medical Center. It works to manage care and dignity, all of the decedent affairs of people who have donated either their body or parts of their body for research. And it also is a place for people who are unclaimed after their death to provide them with a dignified burial as well. Next slide. So part of a key part of this, and really kind of the public health time here, is the anatomic donation program. The Organ, Eye, and Tissue Donor Program. There's work with the Brain and Tissue Bank at the University of Maryland. There's work with medical schools and physician assistant schools and other training institutions for anatomic tissue donation. But I do want to highlight also just the dignity that this program provides to, as I mentioned, people who are either unclaimed in death or whose families are unable to afford a burial. The State Anatomy Board provides that burial, and actually, I believe it's 3 times a year, does a service to recognize those who have passed and to bury their remains. Next slide. We're getting to the end, I promise. This part is new. It's less of an office, and it's more of a function within my office in public health. This is a public health workforce and infrastructure office, and it's really focused on a couple of things: accreditation, data modernization, workforce and infrastructure capacity. And in this context, the workforce is really more internally focused. How are we developing the workforce at public health services in the Maryland Department of Health and in local health departments? Whereas when I talk about population health improvement, that is workforce throughout the state across a wide variety of sectors. Next slide. So key functions here are public health accreditation. Hi, Rita. Thank you. We just submitted our reaccreditation paperwork. I think it's almost 2 weeks ago to the day now. It is a core part of making sure not just that we have a floor in terms of quality, but that we're also pushing to do better, which is that quality improvement work, that performance management work, strategic planning as part of that. But also a large push is data modernization, making sure that we are not just updating our systems so that we don't become obsolete, but really looking at how we're using data properly to be able to do 2 things. One, make sure that we are identifying individuals who need the care they need when they need it, but also properly aggregating that data and making sure that we understand trends, we understand the fabric of what's happening across the state, and even beyond that. Then, of course, managing some of our higher profile grants, particularly our public health infrastructure grants from the CDC. Next slide. So I mentioned our public health accreditation. It is already kind of talked about it a little bit, but it is a really important piece of what we do. I think accreditation really forces you to hold your feet to the fire. We all say we know what we need to do, but sometimes we need a commitment mechanism, and sometimes we need some technical assistance. Sometimes we just need a hand to help us know what we need to do. And so FAB accreditation is a core part of what we're doing in our office. Next slide. I mentioned the public health infrastructure grant. This is a fairly this doesn't happen often. We usually don't get 5-year grants from the CDC to actually invest in our workforce as we see fit. And yet, this is what came out. This is a product, I think, of what happened during COVID and the impacts it had on the public health system around the country. So this is as I mentioned, it's a 5-year CDC grant that focuses on 3 core strategies. One is building up the workforce. The second is foundational capabilities. Things like our procurement processes, our HR processes. We actually just had a great 2-day session with ASTO and HMA to really look over our procurement processes. One of the most fascinating things that I've ever really been a part of. There was a light piece of paper that just crossed about a 15-20 foot wall, and they were mapping out our procurement process, and there were no less than 75 post-its spanning that, going in 2 different dimensions. and that shouldn't be possible. Somehow it is. It's no wonder that procurement takes in excess of a year. You have to hit 75 post-its at Fidelity. That is a beast and a half. But this grant is allowing us to be able to do that work, to really dive in and see, okay, where are we gapping? How can we improve that? And then the last piece is that data modernization, and really looking at, like I said, not just upgrading our platforms, but also looking at how we're connecting that data so that that data is actually useful and meaningful and not just being collected and being used. Part of this is that 40%, at least 40% of the funding has to go to LHQ. Next slide. Public health workforce development, I mentioned this part of the workforce development is really focused internally on our work. How are we attracting and recruiting qualified candidates? How are we really building a culture where people want to stay, where people want to belong? And part of that is giving people the opportunity for learning and advancement in their careers. One of the really lovely things I have felt privileged my entire career to work with really wonderful people, whether that was at FQHCs, Health Department, the Maryland Department of Health. But you know, there are a lot of ways to do good in the public health domain. So what are we doing as a public health workforce, the Maryland Department of Health, to make sure that we are getting and keeping the best people throughout their careers? Next slide. We just have to brag a little bit about our internship program, show you some of our interns. We are, Vanessa here is helping us to build out our internship program across a wide variety of learner types. I think that's such a core part of the work that we have to do as a department to beat that up. I'd like to say that we have these programs, but they're just sort of scattered and based on the interests of people. Our goal is really to figure out how we're gonna, we don't need to centralize it, but how we're gonna organize it and really be strategic about where we want to build these internship opportunities. Next slide. Data modernization, I mentioned, just included a couple of slides here to give you a sense of this, but fundamentally, next slide. Our goal is to take this honeycomb. I always love this slide. I'm a big visual person, but it gives you a sense of the magnitude of systems that we are trying to manage and corral, and make sure that we are updating, modernizing, and connecting those systems. I'm always amused when I find out that one of our systems developed 20 years ago is running on a RISC server, is doing some other ridiculous thing that is absolutely not supported by reality anymore, and yet it still functions, right? And so there's a lot of effort on this space. Next slide. That's it. That is the run and gun version. Obviously, I'm happy to take any questions you have, and I'm happy to share any additional materials on any of those areas that you would want to go into.
Thank you very much. I've done a wonderful job and really appreciate all the work that you and the team and the entire Maryland Department of Health is doing. It's really unappreciated work in many ways, but so incredibly impactful. We are getting up close to our break time. So if there are any comments or questions from the commissioners in the room, we'll take those or try to take one or two of those before we break for time. And then, of course, Melissa's just here during break if you have additional questions. Any comments or additional questions from the commissioners?
I have a question, and specifically, I'm sitting on the workforce working group. And one of the quandaries we had right off the bat, I think Brian and Bob are both on, is for the good of the commission and our work, how would you define the workforce that we should be looking at? Because, as you're presenting all this, it really is a huge amount of people, right? There's a medical care component, there's the examiner's office, there's all that, and I realize there's some direction in the legislation, but for the wants and needs of you at the state level, what workforce, how would you define the workforce?
Yeah, I think it requires that kind of granular level to say, what are we talking about, right? We a lot of the folks that form kind of the core of our work are trained in public health. But there's also we have a lot of healthcare provider types, nurses, physicians, But we also have other types of work, toxicologists, right, laboratory scientists. We have, and then we have people without an education who provide a lot of other support or a lot of other experience. And so I think that, you know, I'm scrolling through what are all the needs that we have. We're going to have to take a little bit more of a granular look at, you know, what are we talking about? Where are the gaps too, right?
But I think that's almost a critical feature here is as opposed to us defining what is the public health workforce, because that could be a wide definition, is in essence is making sure that we're engaged with the local health departments and the state health department and basically say is what are your, for want of a better term, what are your problem areas, right? In terms of recruiting, in terms of retaining, in terms of expertise, right?
Yeah.
And almost taking it from that approach, right?
Yeah.
Almost back to a functional aspect of the workplace.
It's really for maybe another meeting. I'm wondering either from Ramesh, a SWOT analysis, what are the, learned about the different boroughs, programs, et cetera, administrations, but from a strengths, weaknesses, threats perspective. And then for another meeting, maybe, I don't know, the interns can provide health outcomes and compare us to other states. We talked about Indiana and part of why Indiana embarked on it was they were not having the outcomes they wanted. So how does Maryland compare based on whatever the outcomes are?
So happy to do more on that SWOT. On the second piece, the outcomes. So right now we're going through our state health assessments and state health improvement process planning. By somewhere in the middle of March, we'll have a set of measures that are our state health improvement plan. That will be a part of our state health improvement plan. That I'd be happy to share here. I don't think it'll happen for March, probably for April, definitely for May. That I think will give a good oversight of what are the measures that we're focusing on as a state, and that will include how are we doing, whether that's comparison things like Health Group 2030 or state rankings, we can do that.
Awesome.
Thank you. Sorry.
Just Boris, just back to the workforce, and it's related to both the presentation and the question. I mean, I chair strategic planning and serve finance committee for one of the big hospitals, and like the wages are bananas, right? Like it's like I don't know how you operate a business with 20% year-over-year pay increase, right? And you know, I think the Indiana report was looking at the healthcare workforce for the state, and that might be aggressive for the committee, but it seems pretty relevant to access to care issues, to you know, the mission of public health in the state that we, you know, and you have an agency in there that.
So I can expand on that a little bit. So our Office of Population Health Improvement is looking at the state health improvement. So right now they're in the process of so we don't have good data as a state as to what our healthcare workforce looks like. So when we go to our boards, all the different boards, professional boards, their data is they all collected it in different ways, and it's not robust enough to be able to describe what's actually happening.
Sounds like a recommendation.
So hold on. So we've actually done, we've actually worked to identify what do we need to do. Virginia does a really good job of this actually. They started 10 years ago, so 10 years ahead of us, but they provide a really good example of what that looks like to be able to look at healthcare workforce and be able to understand the trends and where you need to invest. So right now we're in the second step, which is bringing together a range of those boards, MCOs, insurers, trying to bring together pretty much labor and schools to bring together what's that picture, how do we build that picture of what our, how do we paint that picture of what our healthcare workforce is. So that's underway, and at some point be happy to elaborate more on what's happening there.
Well, I wonder if there's someone there in the staff that's involved in your committee.
I have three things really quick to say that in the last, that's an amazing job. So thank you for that putting that together. Yeah, great. It would be really wonderful if we do have a chance to meet with the secretary, because as dense as all that is, as rich as it is in public health, There's some other stuff going on at MDH that is very germane to public health. That's not part of Nalesh's administration. Specifically, I'm going to call out behavioral health. You know, if you're talking about overdoses, if you're talking about suicide, if you're talking about youth mental health, these are public health problems. Violence, these are public health problems, and they're in the behavioral health now. So I just really want to bring that to the commission's attention because that is absolutely spelled out in the legislation that we have. Second and third point, lastly, is that as enormous as MDH is, there are some very, very powerful health policy decisions that are made outside of MDH, and those are in 3 commissions. And the number one is the Health Services Cost Review Commission, which has a ginormous influence over healthcare policy in the state. It is very unique to the state, and all of us in our work groups need to look at what's happening, the decisions that are being made at HSCRC vis-a-vis the overall healthcare system, because it's no longer just about hospitals, it's about the total cost of care and population health. So that's part of public health. There are no public health members of that commission.
Well, Josh.
Okay, so yeah, okay, well, yes, okay, so yeah, there's the
Sure.
there's the chief strategist, but the legislation, the statute does not call for any public health representation on that commission, nor on the other 2. That's the Maryland Healthcare Commission that Chris brought up, that has a lot of diverse actions and policy, and then there's the Community Health Resource Commission that puts out a lot of grants. So all that's in our portfolio to take a look at. So as enormous as Nalesh's job is, trust me, I know, there's more out there too. So, thank you.
I think we're going to move to the break, and given that we're at about 3:50 almost, we'll reconvene at 4 and hear from our team visiting from the Public Health Accreditation Board, as well as some brief updates from each of the work groups before we adjourn. Thank you, everyone. So we'll reconvene at 4.
Great job.
Thank you, Nalesh.
Yes.
Oh, sure. Yeah, she created that. Oh, yeah. We can do
How'd that go?
Yes.
Yeah, and that needs a someone.
Yes, yeah, they're gonna. Yeah, I mean, there's.
Oh, it might have been, but I was.
All right, thanks everyone for coming back. We've got a really important last hour. And we are just excited to have everybody in the room, excited for the discussion. I'm gonna pass it over to Commission Co-Chair Tosin. I think she's here in a moment. But while we do that, just as a reminder for everybody who's received the messages, we'd love to see your face this evening. You're welcome to join us at the social mixer of the commission. Starting at 5:30, and I think it's on her way. I'm sorry. She's gonna be here. Tosin, thank you for introducing our two speakers from the Public Health Accreditation Board.
Absolutely. So today we have special guests here with us. We have Rena Trucker and Jessica Solomon. They are both from the Public Health Accreditation Board. They'll be giving us a presentation on the assessment tools that will be critical, right, for the work ahead. We already know we're on a timeline, and so we want to just take a look at all the tools that exist. And of course, in our research, we're finding out other tools, but I think this would really inform the next step in this commission. So just a bio, Rena is the Senior Director of Public Health Systems and Services at PAB, that's Public Health Accreditation Board. There she's responsible for planning and implementing all the innovation projects. And she also supports health departments and communities in their work in an effort to advance health equity. So Rena earned her Bachelor of Science degree in chemistry and a Master of Health degree from Emory University. Please join me in welcoming Rena. And then I'm going to also introduce Jessica. Jessica serves as the Chief Operating Officer at PAB as well. She joined the organization back in 2015, and there she's held different positions, including Chief Innovative Officer, Vice President for Strategic Initiatives and Program Operations. In her role now, she manages business operations while driving PAB's strategic priorities. Jessica holds a Master degree in Community Planning from University of Maryland School of Architecture, Planning and Preservation, and she also holds a Bachelor of Science degree in Geography from University of Ohio. Again, also join me in welcoming Jessica. They prepared a wonderful presentation here, and just sit and enjoy. Thank you.
Thank you. Well, thank you for having us. We're thrilled to be here, and I think we're going to try to talk quickly because I think discussion is the most important part. But I want to start by just saying kudos on the work you've done so far. This is a lot, and it was really impressive to look through your materials and then to hear even the discussion and see the meeting minutes of what this commission kind of has done to start standing itself up in a short period of time, and how you are laying the foundation for the response that you're providing. It's tremendously important work. Very smart to partner with CDC Foundation and their wealth of experience, and we hope with us for ours as well. And I also just want to say you're not alone. So there are other states that we're going to talk about today that have engaged in similar work, have been on similar journeys. And there's no GPS kind of routes to get you where you're going, but there is kind of a high level map. So it's a geography major, I have to talk about maps. Love my maps. So you're kind of on a good path, your early days, but there's people have paved the way a little bit for you, and your path is going to look different as well. So here's what we're going to talk about today, just a little bit about FAB transformation, our 21st century learning community, specifically the tools that we have that we hope that you'll use on this journey, and then discussion. So of course, we have to start with a little bit about FAB and who we are. We are the voluntary national accreditation program for governmental public health departments in this country. We also accredit military public health installations and do some international work. Beyond that, and the work that Rena leads is really around fostering both innovation and transformation in governmental public health, and really leading with sustained statewide systems building through, in part, our 21st century learning community, or 21C, who you'll hear about in just a bit. We are also one of 3 national partners funded to support the public health infrastructure grant work that you heard about during our last session. So a lot of money went to 107 jurisdictions, and then to 3 national partners to provide technical assistance and other support to those jurisdictions in their transformational work. This is the Foundational Public Health Services model. FAB is the national home to this model. By way of history, this was born, it looked a little different, but it was born out of a 2012 IOM report on public health financing, where a group, not dissimilar from yourselves, but a volunteer group called the Public Health Leadership Forum was charged with putting together what a minimum package of public health services might look like, to outline the unique responsibilities that are specific to governmental public health. We then took over the stewardship of that model, made some updates, revisions, made the graphic prettier, included equity not only as a foundational capability, but also kind of all around the outside. And so what we have here are the foundational capabilities, which you see at the bottom, which are the cross-cutting skills and capacities that are instrumental to the work of governmental public health, and that is the public health infrastructure. On top are the foundational areas, which are some of the programmatic service areas that governmental public health departments ought to ensure are provided in their communities. And the very small text at the top is all of that other stuff, community-specific services that are specific to that department or that governmental public health system based on those community needs. So at the state level, thinking about what is in the state health assessment, state health improvement plan, and then how does that state health department and those local health departments respond to that. And that's going to look different from state to state.
If I just make a quick point again, not to relate what I just said, but behavioral health is not considered a foundational public health service. And I get that, but that might change. I'm just saying, moving forward as we understand more and more about drivers of health, not to have behavioral health as part of that picture, I think could merit some discussion.
Sure. And I'll also say, Rena will talk about our 21st century learning community, who are states who have adopted this model as part of their transformation efforts, and they all actually agree we should try to adhere to the national model so that we're apples to apples across the nation. And there are some cases where some of the definitions or some changes might make more sense for your state. And so, this isn't carved in stone. This is the national model. It was meant to be broad enough to cover all health departments, but there is variation, absolutely. And so that's certainly something you all could choose to do.
Are you ranking states?
We are not ranking states.
That would work with the business model, or why not?
As it relates to their assessment work.
You're kind of like a report card provider, or maybe I misunderstand.
So 2 different things. So we are the accrediting body. We accredit state health departments, local health departments, et cetera, and we have all of that data. We share that data with researchers. We are building a data visualization platform right now where health departments can benchmark themselves. But we don't put out a ranking. There are things like the county health rankings, which were, I think, alluded to not by name earlier, where there are ways that states or locals can compare themselves, but we don't name that.
But like even by certain, you're good at this, not good at that.
The
foundational public health services model is baked in to our accreditation standards and measures. So we have 80-some standards and measures for initial accreditation as an example, and 34 of them directly align with the foundational public health services. So in that way, these models are very aligned. The foundational public health services and specifically the foundational capabilities are also the backdrop for the entirety of the public health infrastructure grant. So this framework or model is very well embedded in the field at a national level. And then as you'll hear shortly, in more than a dozen states that have adopted this framework to try to better define what governmental public health ought to be, how much it costs, and more. But I don't want to steal Rena's thunder. She's gonna get to that in a little bit. So we do have the 21st Century Learning Community that we'll talk about, again, with these 18 states that are doing this work. And they're also, go back one, the basis for estimates like we put out in 2021 with the Development Foundation on workforce shortages nationally. So these were with pre-COVID numbers, and the finding was purely for the foundational capabilities. So not for everything that health departments do, but only for the foundational capabilities at that time. We were 80,000 workers short. Had nothing to do with surge for COVID and didn't account for all of the rest of that model. So that's where we were starting from then. And then of course we know about the workforce shortages we have now as a result of burnout, turnover, et cetera. But we're not here to talk about that. But as you're all working to make recommendations on the foundational capabilities and on the foundational areas, you know, this is the framework, I think, that underpins all of that. Again, we're the accrediting body. I talked about our advancement of the foundational capabilities specifically through version 2022 of our standards and measures. During the accreditation process, departments have the framework for communicating what public health is, what it does, having a structure that assures that all parts and the whole of the department are working to deliver comprehensive public health services based on national peer-reviewed standards. And this is also a quality improvement process. These are not minimum standards. These are not maximum standards. They're somewhere in between, also with the identification of areas for continued improvement. As you heard about before, the state health department is accredited. We've got about 12 local health departments of the 24 in Maryland that are accredited, which is good. It's 50%. We'd love to see more, but that's good. And so really in a lot of states, accreditation is one key driver to transformation. It's really not just a checkbox, but it really does have a deeper meaning and value to go through that process in the health department. So these are the 21C or 21st Century Learning Community states. So for more than 7 years, FAB has been working with these states on their modernization and transformation efforts. There are 18 of them. And when we talk about states, we really mean statewide systems. So this means the state health department, the local health departments, other public health related organizations like the State Public Health Association or the State Association of County and City Health Officials, sometimes schools of public health. And in states where they exist, often tribal public health departments as well. And these states are implementing work similar to the work that you're talking about today. So they're working in various ways to build the foundational public health services, to catalyze change, and we support them through our learning community, through their ability to come together as peers and learn and share and steal shamelessly from one another, which they're all very willing to share and contribute in a way that, quite honestly, I've never seen from a learning community before in all my years, and then diffuse those learnings out more broadly to other states. So we'll share more examples of this in a little while, but I do want to note, this started with 3 states back at the end of 2015 into 2016. Now we're up to 18. And again, they're all doing work that is along the same lines, but it looks a little different because, of course, the context in every state is going to be different. The players are going to be different. Some, like Maryland, is driven by legislation. Some is not. Some is grassroots from the local health departments. Some comes from other kind of drivers. But when I say you're not alone, these are your friends. And they have a lot of really great things, I think, to share with you. And I think the public health infrastructure grant is also really nicely aligned with this work. Obviously, the grant goes to all 50 states and some directly funded cities, as well as the US territories and really associated states. So our work with 21C states and other state systems has been really framed around this kind of general framework, which I know is small, but we'll talk through, and really takes a systems approach to public health transformation, starting with the development of a vision, the adoption of a framework, the FPHS being that framework, and then part of that step really focusing on defining the system and ensuring the system is in alignment with where it sees the vision in the future. Then we look at assessing the current landscape. So what is the current spending and capacity towards the Foundation of Public Health Services using a tool like our Foundation of Public Health Services capacity and cost assessment. And we encourage doing this in a systems approach. And so that means all of the local health departments and the state health department completing that assessment and rolling that up to get that complete picture. So what that assessment does is look at where are you with regard to achievement of the Foundation of Public Health Services and how much does that cost? And if you wanted to get to kind of full implementation, what is that gap? And then that gap often becomes the number that eventually goes to the legislators as a funding request, perhaps not all at once. So building the relationships and advocating for that sustained funding for public health based on that assessment and gap data. And then, of course, implementing approaches to transform the systems to actually build foundational capabilities, strengthen foundational areas. And that could include things like service and resource sharing, between or among local health departments, as an example. So you heard a little bit about the Public Health Infrastructure Grant earlier, so I'll just point out a couple of things. This truly is a historic investment from CDC. So it was over $5 billion that came out in flexible funding to support infrastructure, to support all of the things that never get supported in public health. Public health support is often categorical, it's disease specific. It doesn't care that you have outdated systems and no workers to do the work, but this grant does. And so they've even meant structures and processes within CDC to accommodate the flexibility that this funding affords. And of course, Maryland is a recipient of this grant, as well as Baltimore. I believe Baltimore City is the one directly funded local health department. And then as you heard, 40% of the funding is meant to go to local health departments. So you can see here what the kind of focus is, both on workforce, on the foundational capabilities specifically, and on data modernization. And there have been a few extra boluses of data modernization related funding that have come out lately as well. Give you the numbers, but it's over $5 billion at this point that's out in the field for 5 years, which is a long time for public health grants, although not a long time in the grand scheme of things. And I think everybody's working on this also with a real eye towards sustainability and making infrastructure and systems changes that will outlast the funding, while also using that as an opportunity to look locally at what needs to be done for sustained governmental public health funding, which of course is exactly what you're doing. So this is really nicely aligned with the work of the commission, with the work at the national level. And there's just a lot of supports, I think, right now to help you all as you consider what your path forward is to advance this work in Maryland. So with that, I'll turn it to Rita.
Jessica, so we're going to shift gears a little bit and dive into some of the tools that we have available for us. And I know that's kind of top of mind in terms of where this commission is at and the next steps, or current steps. So I'll, on a high level, talk through these and then dive into a couple of the assessment tools that we have available that Jessica alluded to. One, we do have a guide to transformation that really is built from the learnings from all of those 21C states that Jessica mentioned, that talks through generally what were the steps they undertook to go from defining what they're trying to transform all the way to securing investment and testing out innovations to build the foundation of public health services. So that exists just generally for anyone to use. And then 3 assessment tools we have available. And again, I'll dive into these in more detail. One, and all of these are focused on the foundational capabilities, foundational areas, using the Foundational Public Health Services framework.
The workforce calculator is an ability to assess and input current needs, and then it outputs estimated FTEs needed to provide the foundational capabilities and foundational areas. I'll talk more about specifically what that looks like in a moment. The readiness assessment is a tool to support health departments and health and systems within a state to assess readiness for accreditation for our Pathways Recognition Program, and really an assessment about the foundational capabilities. So it provides kind of an understanding of, again, that health department and across the system, what are we seeing in terms of our capacity related to the foundational capabilities, and where do we have gaps? And then the capacity and cost assessment, again, for health departments and across the statewide system, an ability to understand what is our current capacity as related to the foundational capabilities and areas, and then what's the current spending related to that, and then how do we understand what we're trying to get to and what's that gap, and then taking, again, using the circle model, what's the amount we need to close that gap, and then what are the strategies we're going to implement to build and close the gaps that way. And then we have service and resource sharing tools and resources to really think about across the state, how should foundational public health services really be delivered to ensure that they're available everywhere for public health to work anywhere? And what does it look like to perhaps share services from health department to health department, across a region, or from the state level? And so we have a variety of tools available to support kind of assessing that, and a roadmap to kind of guide what are the best service sharing and resource sharing models that can support that. And I'll just share that all of these really are kind of different angles of assessing the current landscape around the foundational capabilities and foundational areas. So it can be kind of mixed and matched a little bit depending on kind of ultimate goal that y'all in Maryland. Diving in just in a little bit more detail to some of the tools, the capacity and cost assessment, again, as Jessica mentioned, provides the ability to look at the current ability, what's our current capacity and expertise across the workforce to deliver the foundational capabilities and areas. What are we currently spending towards those items? And then if we were to say we had 100%, what would that look like? And then an ability to understand what the gap is between the current and full implementation. What we've seen from 21C states and what we would recommend from FAB's vantage point is not just doing this at an individual health department level, but doing it across the statewide system so you can have a collective understanding of what that comprehensive picture looks like around the capabilities and areas. And I think that's in alignment with the work that y'all are doing here at the commission. The data can be used to really make recommendations for what funding amounts is needed and how those resources should be invested based on the capacity gaps highlighted. And think about, again, what are some options for how services and resources are shared across agencies or across the system, and to advocate for funding. It's just a screenshot of part of the tool, but we do have, I know this was a question that the co-chairs had raised, we do have templates available for this tool. It's an Excel-based tool, and there's several guides that exist to really guide use of the tool, and have several 21C states who have used or in the process of using and have found it kind of pretty intuitive to walk through. And of course, kind of technical assistance and guidance and facilitation support. The FAB readiness assessment is really a tool to assess across health departments and across the statewide system on the foundational capabilities and understand readiness to pursue accreditation or pathways recognition. Really, this is another kind of vantage point to understand what's our current capacity related to the foundational capabilities based on the foundational capability measures from FAB accreditation. Again, we recommend that this tool is not just used at the individual health department level, but also kind of rolled up at the statewide system level to get that comprehensive look at gaps across the entire state and strengths across the state as well. Then I'll shift to the workforce calculator. This is a tool that was created by us at FAB in partnership with DeVomont Foundation and University of Minnesota and a variety of other partners as a tool for local health departments to estimate workforce needs to provide the foundational capabilities in foundational areas. There are current limitations on the size of health departments that can use this tool. It is health departments that serve a population under 500,000. And that's purely because of the data that fuel the back end. If we were to get more capacity and cost assessment data as more and more kind of systems use that, we can both update the back end and hopefully spread kind of the population size, get larger health departments who are kind of using the capacity and cost assessment and then giving us those data. That's what fuels the back end. So purely a data limitation in terms of the size right now, but can be used to really assess, here's what our need is for the foundational capabilities in areas. And then the workforce calculator will output, here's the numbers that would best support you at minimum to meet those needs. And then there are linkages between the capacity and cost assessment and the workforce calculator. So if you do the capacity and cost assessment, you can get more detailed estimates in the workforce calculator. And then likewise, those estimates can be used back into the capacity and cost assessment to assess what 100% of the foundational public health services look like. So a lot of detail, happy to talk through more if it's helpful. But again, these three are available to really, as ready to go tools to support efforts.
Can I just ask a question at this stage? Do the local health departments in Maryland or the state health department use that calculator? Has that been utilized? Do you know if it's been utilized in Maryland or?
I don't know off the top of my head.
Mm-hmm. Anyone from the locals? Are you?
So I'm Barbara Brookmeyer from Frederick County.
Yeah.
And through the Maryland Washington Council of Governments, the Health Officials Committee, we did have support and it was actually done for us. So 3 of our jurisdictions, or 4, right? So Frederick, Montgomery, Prince George's, and Charles County, somebody had done that for us.
You helped to build the tool.
Yes, well, we didn't provide enough data to really help. The tool was done, we were just some add-ons for a little extra practice.
It goes to the point that actually Fran was making earlier as a reflection of the state health department, but is also a reflection of local health departments in Maryland. Local health departments in Maryland are also more comprehensive in the public health services that they provide for their communities than perhaps in some other states. And so if the public health workforce calculator is focused on a certain array of services, capabilities that doesn't include behavioral health, doesn't include some of the other things that may not be typical in other states at the local level, sometimes this calculator then would not be as meaningful to us. But I think for our purpose, right, moving forward, it's an important, once you map it to exactly what the public health capability and service are we assessing, then at least we have a calculator for those capabilities and services. But to bring it back to Fran's point earlier, it would be nice to see something that emerges in behavioral health and services. Yeah, that's very helpful, and thank you. And I would highlight too, I think, taking us back to the capacity and cost assessment, I think that's where some of these additional considerations for Maryland can be thought through. So really taking a look at the foundational public health services and what are y'all looking to assess here in Maryland, and if it includes behavioral health. And then we have operational definitions that are a part of those decisions, say definitions that are a part of the tool, which really look at each of the capabilities and areas and takes it down another level to an activity level to help bucket then Maryland's activities into each of those capabilities and areas. And then looking at that, then getting an understanding of what's missing, what else do we want to assess that isn't accounted for here. And some options could include, modifying the tools slightly to add in some of those additional areas to ensure they're included in the assessment, or
that, and then looking at both the capacity side, so knowledge and expertise, knowledge and capacity, as well as the cost side. So I think just thinking through kind of the operational definitions that exist, how do you map Maryland's activities to those, and then what else are you looking to assess, and then thinking through what modifications for that purpose. So I think the capacity and cost has more opportunity for those types of tailoring than the workforce calculator right now, because it is just. All right, I'm gonna move through these fairly quickly, but we just wanted to highlight, really in the spirit of you're not alone and there's a lot to learn from other states and a lot from other states, a lot that other states can learn from the work that y'all are doing here. Some of the examples from the 21st century learning community specifically focus on the assessment part of their transformation work. This is really just a high-level snapshot of some of those states and the assessment work that they undertook, and then now in this current biennium, what their funding looks like into public health, foundational public health services specifically. I know y'all have heard a lot from Judy and Megan and others in your last meeting about Indiana's process. So we won't go into detail on that, but just wanted to highlight some of the work here around assessment and then associated funding. A few examples from 21C specifically related to assessment work that is going on now or ongoing. In Missouri, they took some time over the last few years to really define what the foundational public health services look like in Missouri, and so had a slightly tailored or adapted model to really fit kind of how they talk about the foundational public health services within Missouri. Currently, they're undertaking kind of a two-prong assessment approach. They're implementing the FAB readiness assessment across health departments statewide to really get that understanding of readiness for accreditation, but also kind of understanding of capacity related to the foundational capabilities. And then they're also implementing the capacity and cost assessment to get capacity and cost data related to the foundational capabilities in areas, to bring all of that together to really get an understanding of if we truly want to have this minimum package of services available across Missouri. These are the areas in which we need to invest more. This is what the funding is going to look like, how we can bridge those gaps between current capacity and we're to have 100%. And we've really been supporting Missouri in their efforts to kind of conceptualize this and implement it. So we're excited to see them go through the process and use the results to improve Missouri's public health system. Wisconsin has coined their public health transformation work, Wisconsin Public Health Forward, really leveraging the Public Health Forward recommendations that were released years ago now. That really outlines kind of what's needed for a transformed public health system. And so they are using their infrastructure grant dollars. They just completed the capacity and cost assessment and are across the system of health departments, local and state, and are talking with tribal public health departments to tailor that tool and use in that context as well. And then they're supplementing that with an ROI assessment and a related workforce assessment. Both of those tools don't exist yet, as Wisconsin is kind of thinking through what that looks like and what would be helpful to complement what they were able to understand through the capacity and cost process. And then Ohio is one of the three original 21C states, and their impetus was really focused on a couple of things. One, through I think it was the 2012 Public Health Futures Report for Ohio, understanding that they needed more investment into the foundational capabilities in areas. Ohio does have a mandatory accreditation thing that exists for all local health departments in Ohio. And then they've aligned their costing assessment with their annual financial reporting requirements for local health departments so that they get costing information yearly from health departments related to the foundational public health services. So they have that ongoing collection of from kind of baseline through current day of how they're kind of increased capacity and spending, and they're closing the gaps related to the foundational they identified through their early day assessment work. Promise, we're almost done. 2 additional states, and we really wanted to highlight these just to show kind of the long-term approach that is really key to, I think, public health transformation efforts. So these were the other 2 original states, alongside Ohio as the 3rd for the 21C learning community. And Washington and Oregon both spent quite a bit of time early days in really understanding and defining, this is the system that we're trying to assess. This is how we believe the foundational public health service should be delivered across the system, and then doing some assessments, work through the capacity and cost assessment to really understand what the current landscape was, and again, what that, if we were to have 100%, what that would look like. And also really spending time on the kind of coalition building, engagement, leadership conversations to have that kind of support too within Washington. Oregon also codified the FPHS in statute, and they're repeating the capacity and cost assessment currently, or will be starting next month. And I highlight those just to show those states started their work back in 2013, 2014, and have really taken this long-term approach, building block approach to kind of thinking about how they build up to truly transform the system. It's not just an overnight process. So Washington really took this building block approach. They identified the gap in funding needed, which was $225 million needed to close the gap between what they currently had and what they would need for the foundational public health services, and knew that if they got that all at one time, it would not be good. They would not know how to spend it, and that probably wasn't feasible anyway. And so what's the building block approach to close that gap over multiple biennia? And so you can see kind of how they've progressed over time. And I won't talk through this, but this just shows some of the changes from initial to kind of how they've been able to increase the availability of FPHS based on those adjustments. And then just highlighting, Oregon just completed an evaluation report of their public health modernization investment for the last biennium, and they were able to hire 300 new positions focused on foundational areas and capabilities using that funding, and then of course increased capacity. That work. So if we were to recommend an approach for y'all in terms of assessment, it really would be to conduct a statewide capacity and cost assessment after taking a little bit of time of looking through the operational definitions, understanding what it would look like in Maryland, and then thinking about what maybe modifications or slight tailoring might be needed for the tool, conducting them at the individual health department level, and then rolling those results up across the statewide level to really understand the collective picture of Maryland. And these are just some examples for what other states have considered as they've developed recommendation reports. So I won't talk through these just in time. But wanted to close with just some offerings from FAB in terms of how we can support y'all as you move forward. One, leverage your infrastructure grant funding. That's what that funding is all about. And we're seeing other states use some of that funding to do things like the capacity and cost assessment and other assessment work. We're here to support through our role as TA providers. So reach out to us, and we're happy to talk through how we can best support y'all to implement the assessment work. Offering kind of guidance as y'all move forward on that statewide approach, service and resource sharing resources, and then access to, if you do want to join into the 21C learning community, I think just access to all of those other states and the work that they're doing, the history of the work, the current work, and then y'all be able to share with them too, just to really leverage the collective. So with that, I always like the slide and thinking about these are redwood trees, and we think because they're so tall that their roots are really deep and to hold them up, but actually their roots go kind of far and wide, and they intermix with each other and intertangle, and that's really what keeps them standing. It's really the connection and the alignment and coordination that all the roots have with each other. So just to share that there's a lot of others in this space, and everyone's here really to improve the public health system. So another metaphor. That's what we have for y'all.
Thank you. I have a question. You mentioned that one of the states has a mandatory accreditation. I think Ohio. Do you know if the LL outcomes are, based on your assessment tools and data, is there a huge gap in the health outcomes compared to states without that mandatory accreditation? That's one. And the second one is, how many states currently do you have that mandatory? And I'm asking this because part of our work based on recommendation has policy. So just thought it was interesting.
Yeah. Great questions. I'll just say a few things. So Ohio is the only state that has a mandate for FAB accreditation. That came about with a whole host of technical assistance to help health departments move toward that. As you can imagine, it was not well received at first, nearly 10 years ago by the local health departments who said, you're telling me now to do what? But then the state came in and said, we're going to help you. So carrots and sticks, and they've come a long way in terms of the feedback we now hear from the local health departments. We're actually working on an impact evaluation with Ohio right now. So ask me that question in June and I'll tell you the answer to that question.
Okay.
Anecdotally, I can just share with you some of the benefits that they've received as health departments, but can't speak to the health outcomes. There are a couple of other states that have accreditation programs at the state level. So the state of Missouri has a voluntary accreditation program that is state-based. It's pretty small. There hasn't been a tremendous amount of uptake. We would suggest they go to FAB instead. In North Carolina, they have a state-based accreditation program where the local health department used to get money to help them go through it. They no longer do. It is mandatory, but we're working with them to better align it. There's a fair amount of overlap, but then they have some things in their standards and measures that are very North Carolina specific to their program areas. And there's an interest in North Carolina to move more toward the FAB accreditation model. Michigan also has an accreditation program that's really more like program certification. But Ohio is the only mandate for FAB accreditation.
Thank you.
Yeah.
You guys are like a vendor to health systems?
We're a national nonprofit public health organization that was created by the fields. We're funded through fees and we do grant work, like the big work and the 21C work. So we are the only national accrediting body for governmental public health departments. Health departments were one of the only municipal government functions not accredited, right? Fire departments, police departments, your schools, your libraries, of course, all have accreditation programs. And in the early 2000s, the question was asked, like, why not public health? And is there an interest in doing that? So there was a study, and the field said, yes, there is interest in doing that. And thus, FAB was born, and the standards and measures and all of our work is always created by the field, not to the field. But we're a nonprofit.
I have a question for Lash, because the state of Maryland is currently undergoing reaccreditation. So have any of these tools been used for the reaccreditation process?
The workforce plans local department, it's a that. We've been going through, we've been working through for
Yeah.
So.
So the readiness assessment would not have been available for your reaccreditation application, unfortunately. Your next reaccreditation, you'll be able to do the readiness assessment for reaccreditation, but new applicants have that readiness assessment available to them. And once you're accredited, it's a 5-year accreditation. And we work closely with the health departments on annual reporting, which also identifies kind of innovations, areas for improvement, et cetera. But the tools are, you could use the tools and kind of create documentation and get credit towards meeting the standards and measures, but they're not, we don't require that for accreditation.
I just
our capacity and
maybe
cost
you
assessment.
embarked on using the tools that you got through reaccreditation. Suggesting that some of these tools may be helpful.
Thank you so much. That was fantastic, and we really do are excited to utilize your technical assistance. I think hopefully the work groups who are tuning in, the work group members who are tuning in, found some connection with some of the assessment tools that Fab was describing, as well as some of the examples from other states, which I know we'll be following up at a more detailed level. Thank you.
And the other thing I'll add is that they are local, right? They're based in Virginia, so that's, there's a close connectivity specifically.
Excellent. All right. So we're nearing end of time for the meeting, but we're transitioning into the work group updates. So we're going to go around and do rapid fire updates from each of the work groups, and hopefully as we move into our ongoing months of the commission, we'll get more detailed updates from the work groups. January is a very busy month. We launched really all of our work groups. We got people into place. We got first meetings into place. Lots has been going on. The co-chairs are very grateful, and I know our whole commission is very grateful to the CDC Foundation and their collaborative agreement, and the Maryland Association of County Health Officers for this incredibly, I think just a wonderful, wonderful collaboration that will benefit so many throughout our state, and will certainly benefit the work of this commission. Those team members who will be coming from CDC Foundation, CDC Foundation's already put forth some funding to support dedicating some staffing as we start out, and are seeking funding to support the staff that will be dedicated hopefully and soon through their agreement with MICHO. So lots is going on in January. Let's hear from each of the work groups in a rapid fire kind of way, and then we'll be off. Let's start with the communications and public engagement work group.
Dr. Nicole Rochester.
Hi, everyone. I'm Nicole Rochester. So we met on January 25th and really started with the introductions, of course, and really got a chance to see the alignment that we all have and the various reasons that we each chose to join that particular work group. And we were reminded of the charge of the Public Health Commission and our work group. And then we really had a robust discussion that was facilitated by the use of Jamboard. I had never personally used before, but it was phenomenal. And it really allowed for a very interactive method of each of us being able to place our thoughts on the Jamboard with regard to communication and public engagement. So some of the main themes that came out with regard to communication were trust, and then mistrust and distrust. And we talked a lot about the message being as important as the messenger being as important as the message. We talked about the need to go into communities and meet people where they are with regard to communication. There was a lot of discussion about collaboration. We talked about the bidirectional communication and the importance of giving community members feedback and not just taking from them, but also letting them know the results of our work and how that's going to impact their communities. We talked about the need for the communication to be effective and easily understood and in plain language. We talked about how to distribute the information and making sure that we are utilizing not just traditional methods, but also social media as well as texting. We talked about the relevancy of the information, that it needs to be accurate and that it needs to be culturally relevant. And then with regard to public engagement, we talked about the need to shift the hierarchy and kind of the power dynamics that currently exist between the community and the public and healthcare providers, and recognizing that everyone is part of public health. And again, leveraging trusted messengers. We talked about timing and not waiting until there's a crisis to begin engaging our public, and now like really taking advantage of the opportunity that we have now. I dare say post-COVID. I mean, I know we're not post-COVID technically, but in this era where we're not necessarily in a crisis, really leveraging trust and trust building and not waiting until the next public health crisis. And then we also talked about the populations that we need to reach, which is of course everyone, but we specifically talked about the youth, seniors, disabled, those without internet access, and those with language barriers.
Thank you very much. Let's move to the data and information technology work group.
Oh, boy. Okay.
Chris, that was to you, Chris. Just maybe a report out of how the work group's going.
Actually, I did see notes awesome. Jay, I think.
While we're waiting for Chris, let's do the funding work group and then we'll skip back.
Hey, Mina. So we have had our inaugural get together. We did a brief overview of public health in Maryland, and then we highlighted some funding issues, both structurally across the nation, like the U.S. spends 3 times per capita on healthcare compared to the average of other industrialized countries, but the U.S. has one of the worst health outcomes among all industrialized countries, and not coincidentally, the U.S. spends among the lowest in public health prevention. Only 2.5% of healthcare spending in the U.S. is on public health prevention. We talked about how both MDH and local health departments are funded. I know you all talked about an outlier grant with the infrastructure, CDC infrastructure grant, but typically grants that public health gets only last a year or sometimes 2 years, which makes it very difficult to make any long-term planning. And these grants are oftentimes heavily restricted in terms of what we can use the funds for, which oftentimes do not match well with local needs. Local health departments, most but not all, provide clinical services, but these are always clinical services that private sector can't generate profits. So although local health departments can bill for these services, the money that we take in, the revenue we get, does not match the cost of providing the services. We talked about core funding and how core funding is a shared responsibility between state and counties. Mentioned that core funding is heavily contingent on the broader economy. So that when we had the recession in 2008, 2009, there was about a 50% cut in core funding. So these funds are not dependable. And they also are restricted in the ways that can be used. And at least for some of us, we feel that the formulation between county and state contributions are outdated. We also talked about community health benefit dollars and how had a very preliminary talk about how potentially these funds could be better used to really address the social determinants of health across the state. Community health benefit dollars are predictable. They're essentially recession-proof, and they're available across the state. Unlike retained revenue funding, which varies a lot from hospital to hospital. We also had a brief mention of that. So toward the end of the meeting, and our meeting, I think, lasted all 45 minutes, we encourage members to research additional areas of public health funding that may be used in other states, and to come back with suggestions at the next meeting for these creative things, and then also experts in the field who may be able to address our committee.
Thank you. That was Dr. Larry Polsky, the Calvert County Health Officer and co-chair of the funding work group. Let's actually move on to the others, and then we'll wrap back to data. Let's start with governance and organizational capabilities. Grant?
Yeah, thank you. Yeah, we had a meeting last month, and I'm happy to be co-chair along with my partner, Dr. Brookmeyer from Frederick, and Sarah Holt. I can't say enough about Sarah, who's our staff assistant for all the work. There's also, I think, 5 members of our work group in this room right now, and I don't know how many are online. So I feel a little foolish giving a report, okay, because we all know what happened. But let me just, for those of you that don't happen to be on that work group, let me just raise up a couple of things. We're going to meet next week, and then again, got a regular cadence going later in February. Unlike funding, unlike workforce, a little bit unlike communication, organization and governance is kind of mushy. You know, it's not that discrete. And so, yeah, we're going to be looking at some quantitative measures, and we'll look at that. There's an awful lot of qualitative measures around an assessment of governance and organization. And we're not talking about organizational administration in a health department. We're talking about how the thing is laid out, the org chart for local health departments, the org chart for MDH, and then org chart for the state of Maryland. So we are kind of going to be doing some blue sky transformational thinking about governance. I'm just giving you a little heads up on this, okay? We're going to do key informant interviews, and any of you that have any ideas about surveys, about how to structure these qualitative, we really need help on this. We also really need to work with all of you because we want you all to know, give us input on who to talk to and vice versa. So we're going to be overlapping and cross-cutting. But I will say that we're not gonna come back with some check the box kind of recommendations, right? I'm speaking, I'm now speaking.
That's right.
So get ready. Really blue sky vendors in our work group, and I know you all do too, so I'm gonna stop right here.
Awesome.
Let's move to the workforce work group next.
Boris Lushniak here. I think Brian Kasushi and Bob Stevens are on as well, which is our co-chairs. I am a commission member of that group. We had a very successful first meeting on January 23rd. A great turnout from the work group. We realized that oftentimes the work groups are big, and having a good number of people commit is already something everybody needs to be congratulated about. We've agreed to hold meetings the first Tuesday of every month between 11 and 12, so we have time set, and hopefully people will be able to get it into their schedules for our work group members. The key feature we had was discussing the charge of the workforce working group, and specifically questions that I actually brought up several times today is how do we define the public health workforce? And we have to be able to nail that real quickly in terms of that definition. So we've already had some exchange emails during this meeting talking about at least some direction. How do we define what we're going to be looking at? And in essence, also the philosophy. We talked a little bit about this before we did it during our meeting. Should we do the achievable or should we do the aspirational? And back to Fran's point of view, we want to think outside the box. So it's not the simple little things, but also what we want to do is ultimately hand the policymakers and legislators things that they can work with as well. So there's going to be that fine line there. We talked about some of the observations and considerations, right? Considerations of funding. So we actually interplay with the funding group. You don't have the money to hire people. You're not going to be hiring people. The hiring process itself, are we hiring based upon degrees that people have or their experience level and your needs, right? This whole infamous, I'm an MD, but the sense is that oftentimes we say, well, the MDs run the world. Well, maybe we need to look at a different paradigm in public health. Quality, right? Adequacy of staffing in the workforce. And then looking at the resources that are there in terms of data, and specifically one data set that we'll be looking at that the Beaumont has had a key feature in, and the state now has this information, is the WINS data set, which is Public Health Workforce Interest and Needs Survey. That's been done several times. The latest rendition is 2021. You can say, well, it's a few years old. It was published in 2022, but we already have this least data set talking about attitudes and issues and stressors in the workforce. So we'll be diving into that. And the call that went out to all work group members is any other surveys around data sets, or we'll survey the group regarding data sets of information and already potentially out there, or how are we going to be looking at data in the future? So that's kind of where we're at right now, and we'll continue on this path.
Awesome. Thank you. Really, really great work, and I'm eager to see what comes out of that work group. Thank you. Let's wrap it up with the data and information technology work group. Back to Chris.
Sure, and I'll be brief. And many thanks to Jay Atanda who pulled those together for us. I didn't know that I was speaking here, but I'm glad for the opportunity. So we met on January 24th, 9 o'clock for an hour, largely administrative, but included 40 minutes or so of our discussion of like introductory discussion on data needs and possible barriers. Work group members identified the need for information on sort of data systems enhancements, like starting to sort of this idea of sort of what is sort of the assessment that we're going to conduct, that data system enhancements and transformation needed at the local health departments and state. Integration was talked about quite a bit. So both among the public health data systems as well as sort of with the clinical delivery data system, which touch on a little more. Questions sort of about data to action. So like, okay, so we have data, how do we actually do something with it? Like, what are we going to do? And so making sure some of that gets outlined. And then we talked some about barriers. So barriers to meeting the needs above, sort of funding to support the staffing work, and sort of like just doing assessment funding to deliver the services that we would then go and do. So that'll be a challenge to think about. Capacity and workforce development. Workforce development remains an issue. Considering equity, like we need to be doing across all of healthcare, right? So both in the delivery side as well as public health, and and sort of making sure that as we think about these projects, we're applying a lens there. And then legal barriers in data use in healthcare is a big deal. So that was I will just point out that a very important member of that work group commission is here. So Craig, who's the CEO of CRISP, which is an extraordinary asset in our state. It's uncommon. We don't have, other states do not have this real-time connectivity among all of the state's hospitals and almost all of its clinical sites and more. And I'm not going to do the commercial very well, Craig, but.
Thank you. Thank you, Chris, and welcome Craig as well. So great updates from the work groups, and I think just an additional highlight of what's going on in general with the commission and the work groups to acknowledge the University of Maryland and Morgan State University are mobilizing to help with student interns that will help, I think, as Boris had mentioned it earlier, will really help, one, help the work of the commission, right? There's quite a lot that needs to be done, especially in that research background area, but also build our workforce, right? I mean, we really are looking to build the future pipeline of public health workforce in Maryland, and that's one way to do that is by engaging our students in training. The next meeting is March 7th from 2 to 5 p.m. here at the Baltimore County Department of Health. With the virtual option, and thank you again to Dr. Branch and his team for their amazing hospitality. We really appreciate all the facilities, their upgraded technology, which has worked really well today, and their refreshments. Thank you. And for those of you who are joining for the social mixer, there is parking in the back. And I just want to say thank you to Lawrence Barrett from the Workforce Work Group, who is supporting the workforce by promoting connection across our gallant public health, advocates, I think I'll call ourselves. So we'll entertain a motion for adjournment.
I move to adjourn this meeting.
Second. Excellent. All right. And all in favor? Aye. Thank you. I see you, Alan. Thank you. All right. Any opposed? Any abstentions? I'm going to rush through that. All right, we've adjourned. 5:02.
If people want to stay back, if you want to get pictures, commission members, work group members, you want to get some pictures, yeah. Because the last time we didn't have a picture.
Blessing.